We are really lucky having Erika Taparan here. She's a clinical nurse specialist in the Bladder, Bowel and Pelvic Health team at Lewisham and Greenwich NHS Trust. Their team have won the Green Nurse Challenge project with a trial without catheters, and we're really excited to hear more about their project today. So please take it away, Erika.
Good afternoon, everyone. Today I'll be presenting Lewisham and Greenwich NHS Trust Green Nursing Challenge project, which we have titled Trial Without Catheter, or TWOC as it's commonly known, a structured approach. So sorry, my slides are not moving. Oh, here we are. So firstly, I'll quickly introduce my team. So this project was done by 3 people. So first one would be Myra Robson. She is the clinical lead for the Community Bladder and Bowel Pelvic Health Service. And this project was actually Myra's idea. And she was the overall lead for this project. But sadly, she's unable to attend today as she has prior commitments. So I'll be presenting on behalf of Myra. So my name is Erika Taparan. I am the catheter lead for the adult community services in Lewisham and Greenwich NHS Trust. And lastly, would we have Imogen Cotton. She is the graduate management trainee. She has spent the past year working in adult community service and was involved in the data collection side of the project. So she was a very vital part of this as she did the gathering of the data as well as analyzing them. So the key issue this project aimed to address was the absence of a commonly known evidence-based and structured approach to trial without catheter. Indwelling catheters are among the most used invasive medical devices in the UK. Around 90,000 people in England use them long-term. However, evidence shows that the longer the catheter remains in place, the higher risk of contracting an infection. So this is really significant given that catheter-related infections cause about 2,100 deaths each year. Here in Lewisham in Greenwich, we knew catheter-related issues were driving high numbers of district nurse visits, ambulance call-outs, as well as A&E attendances and hospital admissions. But there wasn't any formal data being collected prior to this. We were also seeing high rates of failed trials without catheters. Again, there was no data, but clinicians estimated around 50% failure rate. We were also seeing very high rates of the catheters also place a huge financial burden on the NHS. It costs around £2,000 per infection episode. And the total annual cost of catheter issue-related use is estimated to be between 1 and 2.5 billion. Beyond the financial and clinical impacts, the ongoing use of catheter generates a lot of plastic waste through the catheter themselves, as well as the associated clinical gloves, aprons, and maintenance supplies. So our primary goal was to optimize the success rate of TWOC, ensuring that catheters are removed as soon as clinically appropriate, reducing overuse and the length of time catheters are left in situ. So our secondary aims and expected outcomes were to reduce catheter-related district nurse call-outs, ED attendances, ambulance call-outs, and hospital admissions. We also aim to reduce environmental and financial expenditure on catheters and catheter-related products, including plastic gloves and aprons. We also wanted to improve integration, communication, and patient pathways between clinical teams, including community service, the emergency department, inpatient wards, and urology service. We also wanted to improve staff confidence and practice through targeted training and support in catheter care, and to embed a TWOC and catheter-related data collection process into the service as this had previously been neglected. So how did we go about achieving these goals? So the first step was to create a Band 7 catheter role, which was filled by myself. I'm quite new to the role. I've only been here a year and a half. This role did not exist before. And so because of the issues relating to catheters in the community service, they have created this new role for me. Once in post, I have set up a formalized TWOC review service. Now, any patient needing a community TWOC is referred by the district nurses, GP, or hospital staff. I review each case, checking the notes, speaking with staff, and contacting patients or carers if needed to confirm whether a TWOC is appropriate. To support this, we designed a simple classification system to group patients based on their readiness for TWOC. So we've categorized that to ready, not ready, or potentially suitable with some preparations. So this helped ensure patients were seen in the right time with the best chance of success. We set a target to triage referrals within 6 days. Patients are then contacted to plan the TWOC, either at home if they are housebound or in clinic if they are able to attend. After the catheter is removed, a follow-up plan is agreed, or if a TWOC isn't suitable, an alternative plan is arranged with the referrer, and the patients are made aware of them as well. Once tested, we expanded the process to include district nurses. I and Myra have trained them, along with the new Bladder and Bowel champions that we designed for each district nursing team. These champions meet monthly with us to review progress, as well as if they need to raise any concerns, they have questions, or they need more information from us, then we normally address them during those meetings. So within our TWOC service, I collected the following metrics. So the number of TWOC referrals per month, number of patients triaged for TWOC within 6 days, number of patients deemed not suitable for TWOC, number of patients who passed TWOC, number of patients who failed TWOC, and the number of adverse events related to TWOC. Outside of this, Imogen has collected the following activity data. So the monthly number of ambulance callouts for catheter-related issues, monthly number of ED attendances for catheter-related issues, monthly number of catheter-related hospital bed stay, monthly number of catheter-related hospital admissions, and monthly number of catheter-related district nurse callouts. So as part of my data collection for this project, Imogen and I went through the historical data related to these activities and pulled the data points related to the catheter issues. She was then able to use this backdate these activities and establish before and after data for this project. So in terms of our results, we'll start with the clinical results. So the table on the left of the screen shows the results from the TWOC service. So as mentioned earlier, we did not have baseline data before this project. So these are our first recorded results. We can see this is really encouraging. All referrals except one in July were appropriate. That reflects the strong communication around the new TWOC criteria. So the failed TWOC rate was 39%. While there are no reliable national data for community TWOC success rates, anecdotal feedback suggests previous failure rates were slightly higher. With continued auditing and process development, we expect to see these numbers reduce further. Our clinical activity data showed promising results, with all these activity levels reducing throughout the course of the project. I do want to caveat all the activity data results by stating that the improvements reported are assumed, in part to be connected to changes driven by the project, but there are, of course, other variables that may have influence, and only until we have long-term results, we'll be able to make more confident conclusions. That being said, we did see some really exceptional improvements over the course of the project, and most significant improvements were related to ambulance callouts dropping by 25% from 47 to 35 per month, indicating more timely community interventions, and catheter-related hospital beds fell by 32% from 246 to 168 per month, revealing fewer prolonged hospital inpatient stay. So in terms of our sorry. And then next one is our social results. In terms of the social results, we've been seen really significant improvement in staff confidence and understanding of the TWOC process, as well as in the identification of patients for TWOC. We've also introduced the Bladder and Bowel champions in each of the 4 district nursing teams who have monthly MDT meetings with Myra and myself. This has provided teams with ongoing opportunities to learn, share experiences, and build expertise in catheter management and TWOC. So this project also supported the purchase of bladder scanners for all of our district nursing teams. And we've already rolled out regular bladder scanning training, helping to further upskill staff bladder and bowel care. So just an update, because obviously this project was done last year. So all district nurse team have their bladder scanners. Most of them have been trained now, which is very good news in terms of this project. So in terms of our environmental results, the impact, obviously the results show a clear net environmental gain from the project. We saw large reductions in emissions from hospital stays, down by almost 3 tons of CO2 per month, and from ambulance call-outs, down by a further 433 kg CO2 per month. That's an overall net saving of around 3.5 tons every month, or roughly 42.5 tons per year. A really positive outcome indeed. In terms of our economic results, for the finances, the data so far makes a really strong case for the project's value and impact. For the hospital activity, we saw the biggest saving from reduced hospital stays, an average drop of 78 bed days per month, saving around £30,000 each month, or £364,000 a year. For our ambulance emergency care, ambulance call-outs fell by 12 per month, saving £5,500 per month, and even a small reduction in ED attendances of just 3 per month still saved nearly £800 a month. Overall, the project has delivered sustained high-value saving with 0 investment cost. In total, that's an average of £36,800 saved every month, or roughly £442,000 per year, a major efficiency gain for both the trust and the wider healthcare system. So, where are we? Going forward, we are already proud of what we've achieved so far and really encouraged by the early results. However, we know this is just the beginning. There are a lot more to do to embed and grow this work that we've started. Going forward, we'll be training our district nursing team to complete a follow-up reviews for patients independently, as well as carrying out initial triage and TWOC referrals. In terms of that, district nurses now go to the patients on their own to review the TWOC at the end of the day, and they do relay the results, or the only time they would need me is when they have questions and they're unsure during that time. But other than that, district nurses have been doing them independently. We are also planning to set up a high-risk TWOC clinic to provide additional support for complex cases. This is something we feel will be really important to reduce the number of failed TWOCs. We'll also continue collecting our data to build long-term picture on the project impact. In particular, we want to use insights from this project to create a clearer understanding on why some TWOCs fail and the key risk fractures involved. We also currently in the process of developing a formal standard operating procedure for TWOC, and Myra has already begun writing up the project for publication to share our learnings beyond the trust so that others can benefit from the approach and the outcomes that we've had. Thank you. That is all.
Oh, thank you, Erika. That was really inspiring, just thinking about how joint working and just focus on both the environment, also cost saving, and how it's all kind of joining up to also make the patient care better. I just have some questions.
Yes.
So I know you mentioned preparing for removing catheters, and it was just interesting to hear a bit more about what is it that you think clinicians can do to try to prepare and know when someone is ready to remove a catheter.
So normally, when I receive a referral, I look through the notes, not just the referral form itself, but beyond that, I look at CT scans, I look at medications plus medical history. An example that I can give is, for example, a patient had a scan or an ultrasound that says they have an enlarged prostate. They had this urine retention. They were catheterized. I look at the medications. Do they have anything like the tamsulosin, perhaps? And if they don't have that, I'm not booking them an appointment yet until the patient agrees to start the medication if clinically appropriate. Say they don't have any risk factors because of the side effects of the medication, and the GP has prescribed them and have started the medication. So although we are delaying the TWOC, say 1 to 3 weeks time, but that gives the patient a better chance of passing the trial without catheter. Another example that I can give is we do have some patients in community that has had the catheter for say 4, 5 months, 6 months, or sometimes even a year or two. That has no one knew why they had a catheter to begin with. It was just there. For example, they had pressure ulcer, but that's now healed. But since they had the catheter for a long period of time, the bladder may not function as how it was before catheterization. So normally, if the patient is able to do so, we try to prepare them by bladder retraining with a catheter valve on if it is suitable. So to try and regain some feeling within the bladder itself. So those are the kind of preparations normally that I encounter for the patients.
Yeah, and that's such good examples, isn't it? Because I think most people having worked in the district nurses have been to these patients who probably have had the catheter for so long, and it's so important with professional curiosity, isn't it, around, why?
I actually,
Why?
sorry.
Oh, sorry, go ahead.
I actually really want to commend the district nurses in the team, in our in Lewisham community, because they have been really proactive in sending me referrals. They would email me, "Hey, Erika, this patient, we don't know why they had a catheter. Can you please check?" Because obviously, bless them, they don't have the time to do that sometimes. So I try to do the digging. And we did have, I would say, a number of patients just as had it for monitoring mobility problems, or they had a pressure ulcer, but there's no clinical need for it right now. So we try to talk this patient. Some of them might be difficult because they had a catheter for so long and they wouldn't want it removed. That's where some of the difficulty comes from.
Mm. Yeah, no, that's really, that really makes me think that, we are in that way making them dependent on us, don't we? And not necessarily, encouraging the natural process of, and just underpins the importance of your project, I'd say. So what would you say that your biggest learning point from doing this project has been?
Before I started this project, I thought TWOC was just a simple procedure, get it done, and that's it. But actually, getting it done, that someone or like a group of people proactively does it for the patients and not speak on their behalf, but to advocate for them regarding these issues actually help. Obviously with patients as well not having these catheters, the environmental impact to it, as well as the risk of urine infections getting hospitalized. We had a lot here in the community already, especially our elderly, that we have successfully talked and not needing so many call outs, hospital stay, or even urine infections. And I think the impact is so great because we're looking after these people, not just when they ask that they need help, but even proactively doing it for them before they even ask.
Absolutely, yeah, lots of food for thought there. And if there was anyone else who wanted to start a project similar to yours, what would you recommend them to think about both beforehand, maybe during, and also after?
It is challenging because there are people in the community, there are patients in the community that fall out of our radar that still need this catheter, this kind of procedure. One thing that we find as well outside of this project is we did a ED catheter attendance review every month. So I get those data and see, because we found some patients that are not being seen by anyone, not district nurses, not urology service, not by us, and have a catheter attending A&E having these issues. So I think it's more of data gathering. It's easy if you already have this certain people that they know about, like they're under district nurses or some certain team, because they know and they can be referred. But the challenge would be for those who are not known to anyone. I think data gathering, I would suggest the catheter attendances in A&E, because you do pick up some number of patients that, oh, actually they need a TWOC, no one has seen them ever. But yes, data gathering, preparation wise, it is a long process, but I think it's worth it because it's working for us the past year.
Definitely. And I mean, it's things I hadn't even thought about, that, yeah, there's of course so many who might not be known to other services or have the regular follow-up. So during this project, have you also built good relationships with your local A&Es and spread the information to their services as well? Or yeah,
We
how is
do
that?
get the referrals. We've had a meeting with them before, sent it to us. They actually recently I've received an email from Myra that the head of nursing had a meeting with the head of A&E. And they actually commented that there was a significant reduction of A&E visits, patients related with catheters. So yeah.
Wow, that's such good news, isn't it?
Yes, it is. We do see the numbers declining, and obviously, the earlier we remove these catheters, the lesser the problems is, really, because it's gonna be like a cycle of going back to A&E, to seeing GPs or not, or call outs, so on and so forth. So might as well talk to them, and then to get rid of the main problem, which is the catheter, and if they really don't need it, at least the problem is solved somehow.
Yeah. Do you have any like final things you'd like to share before ending your presentation?
I think for services, especially in community, who would want to try doing so, I think it is a really good one. People might think, oh, it's just a catheter, it's just catheter removal, but actually it's more than that. It might sound really simple and basic, but it's not. That's what I've actually learned. That's why I wanted to share that. Because we actually saving lives by this. We're saving the environment. We're saving money. Although it is, I would say, still early days, but it shows in our service that it actually works. It just needs a bit of attention and hard work, and what do you call this? More of teamwork with other services as well.
It really sounds like it was one of the comments that you showed, wasn't it? That they could see how and feel how the care was better joined up.
Yeah,
And
actually,
and
yes.
and that just means so much for the safety or feeling of, yeah, feeling supported from the patient side as well, doesn't it? So yeah, that's really, really interesting. Well, thank you so much, Erika. It's been so good to have you here. And yeah, thank you for continuing doing this brilliant work. I hope that many will get in touch to ask more questions about your project and
Yes.
maybe start something similar up in their area. So yeah, thank you so much.
Thank you so much as well for having me.
Well, thank you.
Thank you.